I would like to welcome everyone to our podcast series on shingles. The goal of this six-part series is to increase healthcare professionals' understanding and awareness of shingles, to reduce healthcare disparities and inequities, to improve healthcare professionals' performance, and to enhance quality of care for patients. During this fourth episode, we will discuss coordination and considerations for routine vaccination, as well as strategies to expand access and reduce missed opportunities to ensure complete vaccination. As we get started, I want to mention that this educational activity is supported by an independent medical education grant from GlaxoSmithKline. Recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the American Heart Association. And finally, does not endorse any product or device. I'll begin by introducing myself. I'll be serving as your moderator today. My name is Dr. Tracy Tavera. I'm a professor of pharmacy from the University of Rhode Island College of Pharmacy and an adjunct professor of medicine at the Warren Alpert School of Medicine of Brown University. Joining me today on our distinguished panel, we have Drs. LeMay and Huang. I'm going to turn it over to have you introduce yourself.
Good morning, Dr. Tavera. Thank you very much for that introduction. My name is Ginger LeMay. I am a clinical professor at the University of Rhode Island College of Pharmacy. I am also a community pharmacist for a large retail chain and an ambulatory care pharmacist in a home health care model. I have a PGY1 residency as well and serve as the residency program director. I've been teaching students in lots of different capacities for many years and also a certified immunizer, have hands-on experience in providing the shingles vaccine. Since 2006, I've been an immunizer and obviously more recently with the shingles vaccine.
Excellent. Thanks.
And good morning, Drs. Tavera and LeMay. So my name is Andrew Huang. I'm an associate professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences. I'm also a clinical pharmacist at the Brigham and Women's Hospital.
Well, thank you to both and welcome to the panel. I think we can jump right in starting with some questions, beginning with you, Dr. LeMay. So how are we currently, or how are specialists currently flagging patients with chronic disease or immunosuppression who would benefit from the recombinant zoster vaccine?
Yes, absolutely. So I'll speak mostly today about my role working in a community pharmacy, as the majority of adults do receive their vaccine in the community pharmacy, which we'll talk about throughout the podcast. So as a review, the herpes zoster vaccine is recommended for all adults in the US age 50 and older, and also for those who are 19 and older who either will be or are currently immunodeficient or immunocompromised. Non-live vaccines, such as the herpes zoster vaccine, we call it RZV, is indicated and is safe in patients who have altered immunocompetence. And we do know that the efficacy may vary in certain patients. It is recommended that they receive it. Oftentimes, patients don't know when they're going to be starting immunosuppressant medication. It could be a quick turnaround time, especially in the case of biologics. So we do recommend that they start getting that vaccine, and that the efficacy may vary depending on the level of immunosuppression of the biologic therapy. So at the pharmacy level, we're mostly looking at age, but we are looking at medications as well.
Okay, great. And Dr. Huang, what criteria or risk stratification tools are we relying on to identify vaccine-eligible patients pre-immunosuppression?
That's a great question. So there are several structural tools that can be used to sort of help make this process more automatic and reliable. So first tool is diagnosis codes. So the ICD-10 codes for conditions such as rheumatoid arthritis, lupus, inflammatory bowel disease, and transplant status. These codes can help trigger best practice alerts in the EHR. The second tool is also medication lists, which can flag patients starting or currently on immunosuppressive therapy, such as biologics, JAK inhibitors, methotrexate, or chemotherapy regimens. And then finally, we have care pathway triggers, which can be essential to the process. And so these prompts can be built into workflows, such as pre-transplant evaluations, infusion scheduling, and new start clinics. These are very high yield touch points where vaccination can be addressed before therapy begins.
Great. Dr. LeMay, you spoke about the community. What access to care barriers do pharmacists uniquely solve for patients?
Right. Well, everybody goes to the community pharmacy, whether it's to pick up some toothpaste or to get your prescription. So community pharmacists are the most accessible healthcare provider in the United States. I think we've all had a situation where we've gone into the pharmacy and had a question for the pharmacist. And there you have it right there standing before you, a doctor of pharmacy who can answer your questions. And so we know that community pharmacists, especially right now with a shortage of primary care physicians, greater in some geographical areas of the United States than others, can fill those primary care physician gaps and also improve preventative medicine. It's interesting, recent data showed that especially for the zoster vaccine, the majority of adults did receive their 2 doses. So just to review, it is a 2-dose series. Give the first dose and then the second one 2 to 6 months later. That over 88% of adults greater than or equal to 60 years of age receive that vaccine from their community pharmacy. So this is the destination for preventative medicine as it relates to all vaccines, but particularly flu, COVID, and the shingles vaccine. What's great about community pharmacies, and for many of those who've gone to pharmacy school, it's often their first job working in the community pharmacy. We have accessible hours. We're open during the daytime, the evenings, 24 hours, holidays. I don't know how many people are getting their vaccine on a holiday, but they certainly can. They can go into the pharmacy and receive that from the pharmacy team. You can walk in and get a vaccine, or you can schedule that appointment. So if you have a shorter period of time that you're available, you could make that before you go to work or after work, or you could just walk in and get that vaccine as well. And the greatest thing about the pharmacy team is that we are insurance experts. So this can often be a barrier for some folks to receiving vaccines. However, pharmacy team, including the pharmacist, the interns, and the technicians, are all adept at processing these claims. So we can troubleshoot any insurance issues that might come up, where that might be more challenging, say, on the medical benefit side. So given all of these things, it makes perfect sense why the majority of adults are going to the community pharmacy.
Seems to make sense to me, and it sounds fantastic. But how do we integrate these pharmacy-based vaccinations with the specialist or primary care provider recommendations to create a seamless experience for our patients?
Exactly. So we have lots of touch points with our patients. So obviously when they come into the pharmacy or when we're filling a prescription or whatever service we might be providing, the first thing we're doing is we're screening them based on their age. So as we mentioned earlier, it is 50 and older for the general population, 19 and older for those who are immunocompromised. And we give vaccines based on a standing order. In some cases, we do get a prescription from the specialist or the primary care provider. This is actually unnecessary, though, because we do work off of a standing order. However, I'll mention that I love when I get a prescription for a patient from a provider, because that might be someone who's not on my radar. That could be someone who's, say, 40 years old, who is starting a biologic therapy, or maybe starting a new medication, as Andrew said earlier, that might flag that this is a patient who will become immunocompromised. So it's actually great to get that prescription, but it isn't necessary per se. As I mentioned earlier, biologic therapies are increasingly more used in patients, and these are not often dispensed at the community pharmacy. They're usually dispensed at specialty pharmacies. So that's not somebody who I may even know is starting an immunocompromising medication. So it is very helpful to have that specialist or PCP. If they send the prescription and we don't quote unquote need it, we can just put it on file. But it is helpful to have that as a mode of communication between providers.
I see. I see. That makes perfect sense. It takes a team to care for these patients.
Exactly.
So, Dr. LeMay, what data do we have, or perhaps maybe even need, to demonstrate that pharmacist-led vaccination increases initiation and completion of the 2 doses for RZV?
Exactly. We know that the power of suggestion by the community pharmacist is the greatest impact to vaccine uptake across all adult vaccines, for sure. One thing I always want to make sure that my team is aware is everybody in the pharmacy needs to be educated about our vaccines. So obviously our technicians may not have as much information as the pharmacist per se, but they can initiate those conversations. They know what that age-based recommendation might be, whether it's for the zoster vaccine or other indicated vaccines. And we know from recent data that when the pharmacist is involved from the beginning, so that's having the conversation, initiation, being an advocate, a facilitator, and actually physically giving the vaccine, that will increase vaccine uptake. So again, you can't underestimate the power of the pharmacist.
Great. And, from the literature, or maybe perhaps from your experience, which patient segments do you think are getting the greatest benefit from access in the pharmacy to these vaccines?
Definitely. So we help everyone, right? We help the very young, we help the very old, and everybody in between, all socioeconomic status. The vaccine is billed under the Medicare Part D part of the pharmacy benefit. So we do find that those patients or those folks who are 50 to 64 years of age, so prior to receiving Medicare Part D, that can be a barrier. Most vaccines, as we mentioned, are given in the pharmacy, and we find that there's greater adherence when it's filled under their pharmacy benefit. Data suggests that 74% versus their medical benefit, which would be receiving that vaccine at a physician office or clinic, that goes down to 48%. So that is certainly something that we need to identify. How is that vaccine being paid for? And we find that when it's at the pharmacy, it's much more seamless for folks and reduces barriers to adherence.
Okay, great.
Yeah.
And Dr. Huang, from a health systems perspective, what standard processes should a specialist use to refer or hand off a patient to a pharmacist to receive their first and their second doses?
Yeah, so when specialists typically refer to patients to the pharmacy for a shingles vaccine, the process should really ideally be, standardized to avoid any confusion and any missed doses. And so the specialist could generate an EHR referral order that clearly specifies the two-dose schedule. It includes any timing guidance related to immunosuppressive therapy. And then patients could also be provided with a handout or a portal message that lists the local pharmacy options, their hours, and instructions for walk-in or scheduled appointments.
Okay, good to know. And how should pharmacists, or how do pharmacists close the loop with these prescribers to confirm the administration and when the next dose appointment will be held?
Yeah, that's an important question. So pharmacists should be documenting every administered dose within the state immunization registry within 48 to 72 hours. And if the pharmacist is embedded into the same health system as the specialist, then the pharmacist should also be documenting this information in the EHR. And then the pharmacist could also send a secure message or electronic notification to the referral prescriber to confirm that dose 1 was given, and then also note that the scheduled date for dose 2. And then this transparency really helps to prevent any duplicate orders and ensure accountability for follow-up and reassure the specialist that the patient is on track.
Great. I mean, it sounds easy enough, right? And Dr. LeMay, what training and protocols help pharmacists address common adverse event questions from your patients or even providers?
Right. So prior to even giving a dose, we go through extensive training to be immunizers. So that requires 20 hours of classroom and so live and also modules to receive that information. Then we also have to have a hands-on practicum as well to demonstrate injection technique. That would be intramuscular vaccines, subcutaneous vaccines, and we have to be able to show aseptic protocol as well. Pharmacists are required to also have continuing education in immunization. That varies by state. So in Massachusetts, for example, where I practice, that would be 1 hour per year, but in other states that might vary. Obviously, we all have to have our active CPR certification as well. And so pharmacy technicians, pharmacy interns, and pharmacists can all provide vaccines. When we go through those modules, as I mentioned, that 20 hours of training, we learn extensively about the adult immunization protocol. And that includes each vaccine. What are the potential risks? What are the potential benefits? And what are those side effects? So we know for the shingles vaccine that sometimes there can be side effects. It's variable. Some people have them, some people don't. I can't seem to find any rhyme or reason to it. I educate everybody about what those side effects might be so that they can be prepared. We often find that folks come into the pharmacy on a Saturday because they're anticipating not feeling well the next day before they have to go back to work. That could include local injection site reaction. So maybe redness or swelling, a little bit of pain there, maybe a fever or chills. GI symptoms. We do obviously screen to make sure the patients don't have any contraindications as well. And we educate them that these side effects can be anywhere from 1 to 3 days. It's really important that patients know what to expect. You wouldn't want somebody to get their vaccine on Monday morning and then be at work, say they're in healthcare and they have to take care of other people and they're not feeling well. You want to make sure that people are fully educated on what to expect from that vaccine. But most people do great, and it tends to be something that they're more nervous about than what actually occurs.
Mm. So the training sounds pretty comprehensive, but it does definitely give me peace of mind that I, as
Yes.
my family member, can safely receive, a vaccine at our local pharmacy. That sounds great. So how do we manage, or how does the pharmacist manage clinical exceptions or complex cases, like such as those patients who maybe just had the shingles or had severe allergies in their history?
Exactly. So, as I mentioned previously, we review every patient for precautions or contraindications. So, if they've had any vaccine related issues, something like Guillain-Barré syndrome, obviously that would be a contraindication to receiving that vaccine. If they have any allergies, we're screening for all of that to make sure that they are an appropriate candidate. We do avoid the shingles vaccine in pregnancy. And if somebody has an active case of shingles, so oftentimes that could be the impetus to want to get the vaccine. We know that when someone turns 50, they know that they should get that vaccine, but they're sort of waiting. And then if they get a case of shingles, that's really what brings them into the pharmacy. From the CDC recommendations, this has been a bit vague. They say not to give the vaccine while they currently have shingles. So if they're experiencing those symptoms, if they have the rash, wait till those blisters heal. Usually it's 3 to 6 months after that active infection. We are strongly encouraging everyone to come in and start the vaccine series. If someone's immunocompromised, they can get the second dose 1 to 2 months after the first dose. We just recommend that it's at least 4 weeks in between those two doses. So I think people would be hard pressed to find folks who are more educated than the community pharmacy team or the community pharmacist as far as vaccines. We have become the destination for vaccines. I remember at the height of the pandemic, we were giving obviously thousands of vaccines for folks. And I remember at one point, coming back into the pharmacy and going to verify a prescription and almost remembering that I was actually filling prescriptions because I felt like I was basically a vaccine clinic. So sometimes it can even take more of the pharmacist's time doing the vaccines than it can filling the prescriptions, which is why you need to have a really solid team in place.
I see. Yeah, definitely a shift in practice for sure.
Mm-hmm.
And so you briefly touched on this before, but what vaccination first prompts, maybe at the point of sale or at medication pickup, can reduce missed opportunities for your patients?
Right. Well, when they come in, that's obviously an awesome opportunity to be able to talk to them. Any of our patients who sign up for digital communications, that could be text messaging or that could be email, they're going to get those prompts that of any vaccine that they're eligible for or recommended vaccines. So once someone turns 50, they get a whole host of vaccines that they're eligible for in addition to shingles. So we do bring that to their attention. We have outbound calls that we make as well. So if we find that from the electronic health record that say, for example, they didn't get their influenza vaccine this year, there's a chance they got it somewhere else, but we're going to do that outbound call just to remind them that it is indicated and we do have that vaccine in stock. And also when someone makes the appointment online, it will prompt them at that time to screen them to see if they're eligible for any other vaccines. So we do in-person, digital, outbound phone calls. We talk about it at the drive-through. We talk about it every opportunity that we can. I found as a pharmacist and also as a parent, we do a great job with our children and not so great a job with our adults. So it is important for us to continue to remind people what they're eligible for. And, the information changes. And so we need to stay current with that information as well.
Absolutely. And it sounds like there's some automation already built in, but how are pharmacies automatically screening for perhaps age and diagnoses to flag for eligibility in real time?
Right. The age one is easy. So we're looking at that. We're looking at that 50 and older. The 19 and older who are immunocompromised, that can be trickier because we, as I mentioned, we may not know if they're taking that kind of medication. As Andrew said, some of those medications that we can easily flag would be like a high dose corticosteroid like prednisone or rheumatoid arthritis. We often fill medications for those patients like azathioprine or also methotrexate. But sometimes it can be a little tricky. And in that case, it is really helpful when we do get that prescription from the PCP or the specialist to bring that into the forefront that that is a patient who would be eligible. We never know what the disease states are unless the ICD-10 diagnosis code is included on the prescription. We can infer what we think it is, but as we know, medications can be used for lots of different things. So it is very helpful to keep everybody in the loop on that information.
True, very true. And Dr. Huang, being an expert in informatics, what reminder systems perhaps would you know have the best performance for RZV dose 2 and completion at 2 to 6 months?
Yeah, so when it comes to ensuring patients complete the second dose, usually multi-channel reminder systems have been shown to be the most effective. But if we had to really pick one, SMS text messaging consistently leads the pack due to their ease of use. They're quick, personal, and have high open rates, so making them really ideal for busy patients. Email reminders are useful for backup, but engagement can tend to be a little bit lower compared to SMS text messaging. And then automated phone calls can help reach out to older adults who or those without smartphones, while app-based notifications can work really well with patients who are already using the pharmacy or it may be a health system app. Ideally, a layered strategy should be utilized. For example, an SMS text message can be sent out at 2 months to remind them for their second dose, and then followed up with an email or a portal message. And then a phone call can be done for patients who haven't responded by the 5 months. By combining these modalities, we can ensure we catch patients across different preferences as well as technology access.
Great. And so do they exist or can we perhaps implement smart reminders that maybe adjust the timing or perhaps the delivery route based on the patient preference of either a pharmacy or a clinic? Do they exist and can we implement them?
That's a very interesting question. And yes, they can be done. Smart reminders can possibly be implemented. These systems could potentially be using clinical data to adjust the timing of the reminders. So, for example, a system can maybe pause reminders around infusion cycles, and then resume automatically when appropriate. In the future, AI-driven solutions can be incorporated to maybe predict optimal vaccination windows based on real-time EHR data, therapy cycles, as well as patient behavior patterns. So there's many more, potential for the future. AI could be used to personalize outreach by choosing the best channel and timing for each patient.
Wow, sounds like a great future. And so, Dr. LeMay, you had mentioned, the key is to getting these 2 doses. Should we be pre-scheduling the second dose when we're giving dose 1? And what rescheduling protocol will help to maybe perhaps support our patients' flexibility and preferences?
Right. We absolutely should schedule dose 2 the day we give dose 1. That actually shows the greatest adherence rate. If you've ever received a vaccine in the pharmacy, if it was the first time you've ever received it, say your shingles dose 1, you're required to remain seated in the pharmacy area for 15 minutes for observation, just to make sure somebody isn't having an adverse reaction or a side effect that the pharmacist needs to address. So during those 15 minutes, they're just sitting there anyway. You're observing them, talking to them, and that's the perfect time to schedule dose 2. You have them there. Now, it's kind of like when you get your dental cleaning and they say, "Oh, how's this appointment in 6 months for your next cleaning?" You really have no idea if that's a good day or not. So we schedule that appointment. If they need to change it, of course, they can change it. They can call the pharmacy. They can use the online scheduling tool. And it really doesn't matter if they come back after 2 months or 6 months. We really want them to pick a day that's most convenient for them. And again, like I mentioned, they often like to do it when they know they can be home for a couple days in case they do have some of those expected side effects.
Makes sense.
Yeah.
I guess my next question is a two-part question. What messaging or what type of scripts are you using to improve acceptance? And are you using perhaps maybe motivational interview with your patients to get them to complete these vaccination series?
Definitely. What I find in the community pharmacy is most patients are seeking this vaccine out on their own because they've had some of those exact reasons. So they've had a family member who had shingles, or their parent had shingles, or they had a previous shingles infection, and they're really nervous about that happening again. So in some ways, we don't have to work too hard, so to speak, because many people are seeking this out on their own, which is wonderful. However, as we previously said, we know the power of suggestion and education by the pharmacist is the greatest impact for that patient to accept to receive that. So what I really try to focus on is what matters most to the patient. We do that with every chronic disease state, right? What is impactful or important to them, and then share that clear and empathetic information. I find you can't convince someone to get a vaccine per se, but you can provide that information and match them where they're at. What do they need to hear? Do they want to hear more statistics? Do they want to hear about potential sequelae of the disease? Where are they? What information do we need to provide? And know that we need to be caring for patients in real time right now. As we mentioned, we do have a primary care physician shortage. It's worse in some area of the countries than others. And community pharmacists can put their eyes on every patient that walks into that pharmacy. If I could just share one very brief story that is very impactful for me, has shaped me as a pharmacist. And this just happened a couple of years ago. I had an older gentleman come in who I knew very well and loved every time he came in, always had a nice banter. And he was there to pick up a prescription. And I noticed that he had redness from his temple all the way coming to his eye. And honestly, it looked terrible. It looked painful. And I asked him, what is that? And I don't know, Ginger. It just happened a day or two ago. It really hurts. And I said, in my mind, I thought, I think he has shingles of the nerve of his eye. So we had an urgent care next door. And I said, I strongly recommend that you go over there right now and have that checked out, knowing how critically important it is to start valacyclovir as soon as that infection is identified. I did do a quick peek in his profile, and he had not received the zoster vaccine as well. He went over there, and within 10 minutes, I had a prescription for valacyclovir from the nurse practitioner at that urgent care. He came back and said, Ginger, I never would have gone there. We were able to get that prescription for him and then schedule that zoster vaccine for 6 months out when we knew that he'd be in a better condition. So these are the things community pharmacists do that are often, they just go sort of unnoticed, but that's part of being a primary care practitioner.
That's great. That's fantastic. Great save. And Dr. Huang, going back to the system, how can we standardize best practice alerts and order sets for the RZV across specialty clinics and perhaps primary care?
Yeah, so to standardize best practice alerts and order sets for the recombinant zoster vaccine, we can start with the system-wide BPA that can trigger on those key criteria that we've been discussing, like age 50 years and older, immunocompromising diagnoses. We should keep these alerts actionable but non-disruptive by offering one-click vaccine ordering or pharmacy referral. We can also pair these with standardized order sets that include the two-dose schedule, the timing guidance, as well as contraindication checks and documentation requirements. So finally, the standing orders for nurses and pharmacists can also be enabled to allow that vaccination to occur without actually waiting for provider approval.
Okay. And what dashboards do we need to track dose one and dose two completion, perhaps by clinic or providers or even by patient cohort?
Yeah, so we'll need dashboards that provide clear, actionable data. So at a minimum, these dashboards should display the dose one initiation rates, as well as the dose two completion rates by clinic, provider, and patient cohort. They should also be able to include filters for demographics and diagnoses so that teams can identify gaps in high-risk populations, such as older adults or immunocompromised patients. And then ideally, these dashboards should be embedded directly into the EHR, updated in real time, and linked to next steps, such as automated reminders. And when dashboards move beyond just reporting, they become a very powerful tool for closing the gaps and ensuring patients complete the full dose cycles.
And that sounds easily done in perhaps maybe an integrated healthcare system. But Dr. LeMay, are vaccines administered in pharmacies, in the community pharmacy, reliably flowing back to the electronic health records and maybe even our state immunization registries?
Yes, absolutely. So when someone receives a vaccine at the community pharmacy, as I mentioned, it is filled as a prescription. So this ensures that it goes under the patient's pharmacy benefit, and so that the pharmacy is reimbursed for the cost of that vaccine as well as the administration fee. So the shingles vaccine is administered for our older adults under their Medicare Part D benefit. Once the prescription claim is adjudicated, as we say on the pharmacy side of things, that information is batched and then sent to the electronic health record, from the electronic health record into the immunization registry in a timely manner, as Dr. Huang said, 24 to maybe up to 72 hours, but it gets there very quickly. Every time I've looked up a patient in the immunization registry, the information is very current and accurate. Every pharmacist has access to the registry as well. We check it regularly. As I mentioned earlier, we're great with our kids' pediatric records, not so great with adults. Oftentimes, folks don't remember what they've received. And sometimes they think some vaccines might need a booster when they actually don't. And again, information changes rapidly, so it's not their fault. That's what we're there for, to provide that accurate and empathetic evidence and information. But in some states, they do require the pharmacy team to check the registry before they actually give that vaccine to ensure that another provider has not provided it. Because, again, sometimes our memories aren't as good. So that information is readily accessible to all pharmacy teams.
So you say it's highly visible to pharmacists, but what standardized documentation ensures that this information is going to be available to specialists and primary care providers also?
Exactly. Right. So that's the second phase of it. Perfect. So once we fill that, when we process that prescription, we say to the patient, who is your primary care provider? We are going to send this record. I have seen it on the provider side. That information does flow into their EHR very smoothly. And so we'll say, who is your primary care provider? They are not required to share that with us. And again, some patients don't have one. But once they do it, we put in the provider's information, their fax number, and our electronic health record automatically sends that record to them. So I think it's critically important that everyone stays in the loop. The providers also have access, obviously, to the immunization registry, so they can be checking that too.
Great. And Dr. Huang, what minimum data set do you think should be shared among primary care providers and specialists and the pharmacists with regard to eligibility and vaccination?
Yeah, so at a minimum, this should include patients' key diagnoses, specifically conditions associated with immunosuppression or high shingles risk, the treatment plan, and timing, such as planned initiation of immunosuppressive therapy and vaccine eligibility status. It should also capture vaccination history, including whether dose one has already been given, and a scheduled or recommended dose dates for dose two. And so when this information is visible and standardized across all care teams, it can help really reduce duplicate work, prevent missed opportunities, and ensure patients complete the full vaccine series.
Great. And just to finally close the loop, Dr. LeMay, who do you feel owns the follow-up accountability for the second dose, when the initiation occurs outside of specialty care clinics?
Yeah, so we found this during the pandemic. Many folks were reluctant to come back to get that second dose. Obviously, there was a lot of changes that were going on. And it was really important when they did return to the pharmacy and to initiate that second dose that they didn't feel any sense of embarrassment or shame. They felt really badly that they hadn't come back for their second dose. We assured them that they did not need to restart the series and worked with them to get that second dose as quickly as possible, whether it was that day or scheduling that appointment. I mean, ultimately, the patient is responsible for receiving the two-dose series. However, whoever provided dose one, it is their responsibility to help shepherd or help that patient to close the loop and to make sure that they do receive that vaccine. So I think that they have to be part of the process, and ultimately the patient does need to be the one to complete that series.
For sure, for sure. Well, I want to thank you both for your time and your expertise. I learned a lot today, and I want to say also thank you to the American Heart Association. I ask everyone to stay tuned for our next podcast on vaccination strategies, common barriers, role of different clinicians, and patient education will be discussed during this next episode. This podcast and future episodes will be available through major podcast platforms. And to claim credit for this particular podcast, we ask you to visit learn.heart.org. Thanks again, everyone.